Let's review anatomy. So we've got 4 valves, 2 AV valves and 2 semilunar valves. What is the purpose of the valves between heart chambers and between the great vessels? Okay, to promote a unidirectional flow of blood. Make sure blood only goes one way. So they open to let blood into the next chamber or into the next organ, and then shut close upon relaxation of the heart muscles, correct? So the pump has only one job, which is to pump blood, and to make sure they pump only in one direction, we have valves. So the valves open and close. Problems result when one or more of these valves start stenosing, meaning when they stenose, they narrow, which can be caused by calcification, any damage to the valve, resulting in the valves not completely opening. So therefore, there is decreased amount of blood moving to the next chamber, resulting in congestion. So therefore, and even if the problem is the other one, which is now if the valve does not close completely, we call those conditions regurgitation, prolapse, or any leak, right? Caused also by calcification. Age causes calcification of these valves, resulting in the valves not completely closing when the blood enters the next chamber. In either way, in either problem, there is resulting congestion. And does this ring a bell from module 1? What happens when there is congestion of blood anywhere in the heart chambers? This will cause what condition? What disease condition will result? That's a symptom, that's a complication, but what's the main problem? When there is congestion, heart failure. Okay, so valvular disorders, therefore, can they lead to heart failure? Yes. So this chapter will not repeat treatment for heart failure because we already talked about that and it was already addressed in a different chapter. So all this chapter will discuss is management, signs and symptoms, and management of valvular disorders. So let's keep this simple. We don't have to memorize all of them. The manifestations will therefore be consistent with where is the valve located, and therefore what type of heart failure will result. Is it left side or right side heart failure? So let's begin with the tricuspid and the pulmonic valve. Where are these two valves located? The tricuspid and the pulmonic. The right or the left side? Both are located on the right. Tricuspid valve between the right atrium and the right ventricle. The pulmonic valve at the door of the right ventricle, correct? On its way to the lungs. So therefore, if these valves either stenose, meaning not completely open, or regurgitate, not completely close, can it result in congestion on the right side? Okay, so what signs and symptoms will the patient manifest? Okay, so all the signs and symptoms of right side heart failure. So John mentioned distended neck veins. Will there be hepatomegaly? Yes. Will there be systemic congestion and peripheral edema? Yes. Okay. Let's go to the mitral and the aortic valves. Where are they located? Left side. So therefore, any stenosis or regurgitation or prolapse of the either valve, what manifestations will the patient show? Which are all signs and symptoms of left side heart failure. Okay, that's it. Let's keep it simple. Let's go now to the management. So the chapter goes piece by piece, valve by valve. Let's not do that anymore. Let's go straight to the management. But of course, based on the location of the valve, which valve disorders are more likely to be serious among the 4? Which are involving which valves? Mitral and aortic valves disorders are more serious compared to tricuspid and pulmonic valves. We also have a higher rate of incidence for mitral and aortic disorders. Do tricuspid and pulmonic disorders occur? Yes, but not as often as mitral and aortic. Why is that? Why are there more cases of mitral and aortic disorders besides infection? No, I mean, why is the incidence higher? Go on, you're getting warmer, John. So why is the left side more prone to damage? Okay, because it's the stronger side, correct? So therefore, the left ventricle being the stronger ventricle, what happens to the wear and tear of the mitral and the aortic valves? Okay, it's faster, okay, because of the higher pressures on the left side. All right, let's proceed with management. So how do we help these patients? So keep in mind, these patients are in heart failure, right? Okay, so therefore, do they see, look at the manifestations, all consistent with heart failure, correct? So therefore, do we treat them the same therapy we discussed in heart failure chapter? The same diuretics, the same vasodilators, same antihypertensives, beta blockers, ACE inhibitors, or ARBs, diuretics, same therapy, exactly, because they have heart failure. In addition to that, however, now the patient will develop some dysrhythmias. So because this is congestion, what type of dysrhythmia is more likely to occur? We just tachydysrhythmia, but which one? Atrial fibrillation. So whenever we have congestion, especially in the atria, this will cause atrial fibrillation or a flutter. Now let's go to the non-pharmacologic management now. So the decision is either to repair or replace the damaged heart valve, depending on the extent of the damage. First of all, diagnostic wise, how do we know whether or not there's a valve damage? How do we see it? How does the doctor see it? The ECG will just show you the resulting dysrhythmia, which will show either tachydysrhythmias or AFib, an echocardiogram. So there are two types of echo. So we have the transthoracic echo, which is the probe just rubbed over the skin, the patient's chest wall, or we have a more vivid picture. If we put the same probe, instead of over the skin, we'll put it into the esophagus and then scan the patient's heart valves through the esophagus, which puts it a few inches closer to the heart. So which one is more, will show a brighter picture? The TEE, which is transesophageal echocardiogram. So obviously the other one is non-invasive, so we can do it anywhere at the bedside, but the TEE has to be done where? Since it's an endoscopic procedure. So in the endoscopy unit, okay, in the procedure room. Any preparations we need to be aware of if it's a TEE, transesophageal echocardiogram? What do you think is the patient preparation? NPL. For how long? At least 8 hours. Okay. For TTE, transthoracic, no need for preparation. We can do it anytime. Before or after meals, doesn't matter. Okay, so let's do repair first. When we repair, that means, did we add anything to the valve since it's only repaired? No. So we either stitched or shaved it off, maybe shaved off some calcified material. We brush them off of the valves. That's repair. So that's also called valvuloplasty. So plasty is repair. Now let's go to the replacement. Okay. Just the next page. Now we go to replacement. There are two options to replace it with. So we either replace it with A biologic valve, meaning valve from a living organism, or we replace it with a synthetic material. When we say synthetic, usually that involves something sturdy, like titanium or metal, for instance. So those are the choices. Again, when we replace, we either use biologic valves coming from another person or from another species, like a cow or a pig, because those animals have about the same size hearts as humans, so they are ideal for replacement. Not really, because these are not per se cells that contain a blood type, or because valves are basically what? They're connective tissues, right? Yeah, so they're not really like other organs or tissues that have many cells and therefore um, have high blood supply and therefore require cross matching and HLA matching. So not really, because these are all connective tissue materials. Okay, so it doesn't matter. Now, the post-op care will depend on what was used to replace it. So if we have valve replacement with a biologic, we have certain rules. And then for mechanical, then we have a certain therapy. Okay, so let's start with the biologic first. Okay, we already talked about TEE. The procedure, by the way, used to be open heart surgery. So before the year 2000, I want to say 2005. Okay, so before that time, the only way to replace a heart valve is to cut the chest open. We have to perform open heart surgery. That's the only way to do it. Today, so after 2005, they started using TAVR. TAVR is a robotic procedure. This is done in the cath lab. Here, catheterization lab. So we are doing the valve replacement through an artery, through a peripheral artery. Either radial or femoral artery is the access. So this is a life-changing procedure because usually patients who have valve disorders age 80 years or older were not candidates for open heart surgery. I mean, they're not likely to survive, right? The rigors of, because you have to divert the blood flow because we have to stop the heart, because otherwise how are you going to change the valve if the heart keeps beating, right? So we had to stop the heart, meaning we had to use a heart lung machine. So 80-year-old patients or otherwise really heavy patients, morbidly obese patients, they were just told there's no treatment for you. Okay, so just say goodbye, enjoy your last days. That was it. Now with TAVR, those patients are candidates again. Okay, so they're pretty much anybody can have TAVR now. So minimally invasive. So we don't have to cut your chest open just to replace a valve today. Sorry? No, through an artery, just a catheter. Okay, and then they can they can insert the valve through the artery. Okay, so let's look at post-op. So these are what they look like. So we've got mechanical valves here, different types, and we've got the biologic valve. Okay, let's do mechanical valves first. Let's focus on post-op care because we're not really involved in the surgical procedure. Okay, again, we're not OR nurses. The doctor performs the procedure. So all we're responsible for is preparation for the patient before we send them off, which is not much, NPO, that's it. And then we send them. And then our our responsibilities resume when we receive the patient after the procedure. Okay. So here are the valves again. We've got biologic valves. We have grafts, autografts. So when we say homografts, that's from another species. Autografts, another person. These are just descriptions on why they would use whatever type of valve. Not really testable because we're not doing the decision making. Okay, so nursing management now. So after the procedure, of course, it's a large artery, right? Which is involved. So what's your main responsibility when the patient comes back? They manipulated a major artery, radial or the femoral artery. They inserted instruments through there. So what's your number one concern? Bleeding, number one. What else? Let's discuss bleeding. So when it bleeds, so how would you know that it's bleeding? Okay, so you watch the site. Is there a hematoma formation there? Is it bulging? Okay, so that's your responsibility. What else could go wrong after you manipulate an artery? Could there be clotting in there? Okay, so when you have blood clots, so that will obstruct blood flow, right? Remember, this is an artery. This is not a vein we're talking about. So if there's arterial blockage, how would you know? What's our concern? The proximal part or the distal part? Okay, the distal part. So what do you check on the distal areas, distal to the artery? Color, temperature, sensation, and movement, right? Okay, so you're basically assessing three things, which is circulation, sensation, and movement. You can also go CMS, circulation, motion, sensation, if that's easier. Now let's go to teaching. Remember, this is a mechanical valve, okay? Now, mechanical valves, because they're made of metal, non-living tissue, what's likely the platelets' reaction to materials like that? What are platelets likely to do? They're gonna stick to it. So when platelets stick to it, what will form? A clot. Okay, so therefore, patients with mechanical valve replacements will be placed on anticoagulants for how long? For the rest of their life. Now, with mechanical valves, the only approved anticoagulant is warfarin. So only warfarin. What do we monitor with warfarin in pharmacology? PT and INR. Now, there are different targets for the INR. For mechanical valves, this is the target. We want the INR between 2 and 3.5. It can vary depending on the cardiologist, but generally speaking, we want it between at least 2 or up to 3.5. Anything higher, that's too much, so we'll have to make adjustments to the medication. Okay. And some doctors even qualify it here. For instance, if it's mitral valve, it's 2 and 3.5. If it's aortic valve, they want it between 1.8 to 2.2. Again, we're not deciding the INR target. It's the cardiologist that will set the target. Yes, sir. No, I won't go into that detail. I just want you to know which type of valve replacement requires anticoagulation for life. Mechanical or biologic? Mechanical. Okay, let's go now to biologic. If it's a biologic valve that was used to replace, we will have to, the patient has a living valve, so therefore it does not require lifelong anticoagulation. Okay, only the mechanical valves, because biologic valves do not tend to attract platelets because they're living tissue. So platelets will just slide over them. They're not likely to attract, meaning platelets won't stick to a living material. Now, both patients though who undergo, doesn't matter whether it's repair or replacement, the fact is, was the valve manipulated? Whether you replace it or repair it, was the valve manipulated? Yes or no? Yes, we messed with the valve. So therefore, is the surface the same as before the surgical manipulation? No. So therefore, is it likely that the patient will be at risk for an infection? Yes. We'll discuss endocarditis on the next topic. I'll discuss that separately. So it's mentioned here, but as mentioned also here, we will have to discuss the prevention and management of endocarditis on a different chapter. But since we're talking about it here, so let's discuss the prevention. So after after heart valve replacement or repair, since the patient is at risk for endocarditis, and the patient, the most frequent portal of entry is the mouth, meaning when you have dental work, let's say, it doesn't matter whether you had a tooth pulled or you had just had your gums, your teeth cleaned. The fact is our mouth clean? And why is it red? Why is our mouth all red? Lots of blood vessels. So therefore, when your dental hygienist or your dentist works inside your head, is it likely to bleed? And even if they use sterile, clean instruments, can you prevent an infection? No, because your mouth again is so dirty. And then once you break the mucous membrane, is it easy or hard for all those bacteria in your mouth to enter the bloodstream? Very easy. So therefore, what do you think we will do, knowing the complications of dental work or any oral surgery for patients who have a history of valve replacement or repair? Prophylactic antibiotics. Okay, so that's the very important, very simple, but very important teaching. So once the patient has a history of valve replacement or repair, they are taught that before you go for any dental procedure, okay, it doesn't matter, cleaning or root canal or extraction, tell your doctor about your history. The dentist will know automatically that, they should do that already. When was your last dental visit? New as a new patient, that you visited a new dentist, no record yet. But how much paperwork did they give you? A lot, right? So one of those questions, if you don't recall, was actually, did you have a heart valve repair or replacement? Okay, that's one of the questions. Another question is, do you have a history of endocarditis? Because once you have endocarditis, then you'll be at risk for endocarditis forever. And this is one of those causes. So if you had a valve replacement or repair, that puts you at risk for endocarditis, which we'll discuss next. Any questions on heart valves? And again, after repair or replacement, remember, did the patient have heart failure before the repair or replacement? Yes, they did. So do we continue the treatment? Yes, because the patient, the valve repair, does that really cure the heart failure? No, the patient's already in heart failure. They already developed it because of the valve problem, and that's forever. Management, of course, is better between an unrepaired or unreplaced valve versus one that is repaired or replaced. Okay, the symptoms, of course, will make a difference. Just briefly talk about cardiomyopathy. So I showed you a picture of cardiomyopathy earlier. So what is this? So this is heart disease. Different types. So it's either, I showed you a picture of dilated. Now let's look at one that's hypertrophic. So you saw how thin the heart walls were with dilated, look at what happens with hypertrophic. It's, oh, sorry. Although the heart here is thicker, here, this is hypertrophic cardiomyopathy on the one on the right. The walls are thicker, correct? But as a result, what happens to the size of the chamber? It's now smaller. And just because it's bigger doesn't mean hypertrophic, doesn't mean more muscular. It just says the walls are thicker, but not necessarily stronger. Okay, so this thickness here is not like the heart went to the gym and then just did biceps and then it got bigger. Okay, it got more muscular. Not really. This is heart disease. It hypertrophied because of the opposite, because this is a weakened heart. So therefore, because it's not working as hard, or it's not, it has remodeled, let's put it that way. Let's say after a heart attack, when this heart develops scar tissue, because those muscles no longer work because they're now scar tissue, will it remodel? Okay, once it remodels, then it hypertrophies, weakening the heart, decreasing the size of the chamber. So basically, when you have this type of cardiomyopathy, are you in heart failure? Basically, still in heart failure. Right? So do you need a new heart? Yes, you need a heart transplant. Okay, so all cardiomyopathy patients have these either hypertrophic or dilated cardiomyopathy. Either way, it's a bad heart. This is now remodeling as a compensatory response. So let's say this side here, this is where you had the heart attack, right? So does this side contract? No more. So therefore, what sides has to compensate for that side? Those guys no longer working. Okay, so the other sides will have to compensate, and as a result, they're hypertrophied. So either way, the patient loses. Okay. Abnormal heart shape. Sorry. Oh, let's go to the causes. Okay, so these are the known causes of cardiomyopathy. Patients who have, let me just, oh, it's right here. Usually alcohol abuse, meaning the patient is malnourished, or let's say viral conditions also, or even complications of pregnancy can result in cardiomyopathy. So here, pregnancy, I mentioned, hypertension, heavy again, alcoholics, malnutrition, or chemo. Okay, so drugs can also cause cardiomyopathy. And this one has its own list of causes. So that was the first one was dilated. Don't worry, I'm not testing all of these. Okay, so just because, just know that what happens when you have cardiomyopathy? Heart failure. And the management, is it different from the heart failure chapter? The same. That's all we need to know about cardiomyopathy, right? All right, let's go now to the infections. Now, they're in the same chapter because whether it's a valve disorder or an infection of one or more layers of the heart, they all lead to the same condition, which is heart failure. They just do it in different ways. In valve disorders, so they cause congestion because of the destruction or damage to the heart valves. In endocarditis, it does it the same way. The infection causes damage to the heart valves, and therefore, does the patient develop valve disorders? Yes, and then they develop heart failure. Okay, so let's discuss the two infections. Let's start with endocarditis. So rheumatic endocarditis ends up the same as infectious endocarditis. which is on the next page here, infective. But let's discuss briefly what is rheumatic endocarditis. What's the difference between rheumatic and infective endocarditis? It's really the cause. In rheumatic endocarditis, we call it rheumatic because this results from rheumatic fever. Now, how do you get rheumatic fever? What are common examples of a group A beta hemolytic streptococcal infection? Strep throat. Okay. So who gets these? Well, anyone who has either an undiagnosed and therefore untreated or undertreated strep throat. So let's say Miss Mira has a strep throat. She did not take the antibiotics, or maybe she took the antibiotics but wasn't educated. She felt better. She stopped taking the rest of it. She didn't finish. So that's undertreated, right? Or let's say she didn't believe it. This is nonsense. So she's, let's say Mira is a old Irish grandmother. Okay, all she believes in is whiskey, right? So yeah, we just drowned sore throat with whiskey. Okay, so she didn't take the antibiotics. So most cases involve elderly in a different generation, okay, that do not believe in the seriousness of strep throat. So most cases you see today of people who have rheumatic endocarditis are older people. No, the boomers. Okay, so the older generation. Do we have rheumatic endocarditis today? Yes, but not as much as the different generation. Okay, because during their generation we didn't know much about strep throat. Okay, we just said, oh, strep throat, that's a common sore throat, but we didn't know until modern medicine came that this was actually what's causing the rheumatic endocarditis cases. So these patients suffered rheumatic fever, developed rheumatic endocarditis, and now they have heart failure because of what the bacteria did to the heart valves. Okay, now it's too late. The patients now have a murmur, especially if it wasn't repaired. And then even if repaired, again, same thing, they already are in heart failure. So it's really treated simply, because how do you prevent rheumatic endocarditis, therefore, since it's caused by strep throat? Treat strep throat. As simple as that. Okay, and how do we treat strep throat? I mean, who has had strep throat here, or your kids had strep throat? How was it treated? That's it. 7 to 10 days of antibiotics, right? That's it. So if a patient today has this, we do the same thing, penicillin for 10 days maybe. And that's it. We prevent rheumatic endocarditis. Okay, so that's why it's so short. All right, let's go to infective endocarditis. Yes, sir. Depends if it was repaired or replaced. Otherwise, you know what causes a murmur, right? The sound is caused by what? Why do you hear a murmur? Yeah, why does it, instead of lub dub, why do you hear lub, lub, lub? Why? The valve do not close, so therefore the leaking sound produces a murmur, right? That's what you're actually hearing, the blood leaking out of the valve. Okay, let's take a look at infective endocarditis. So this is the same endocardium. Endocardium, of course, is the innermost lining of the heart, correct? So how did this get infected? Okay, let's look at because this is an infection, so therefore do we look at the concept of the chain of infection? What are the 6 links again in the chain of infection? The causative organism first, and then the reservoir and portal of exit, entry, mode of transmission, and then the susceptible host. Okay, now the host must be susceptible here. So therefore, is anyone a susceptible host to endocarditis? No. Okay, so there are certain people who develop or are high risk for endocarditis. So let's name a few here. So in this paragraph, they mentioned IV drug users. Why? Okay, they use dirty needles, infected dirty needles, and there you go. Okay, so you're wondering, how did this patient get this blood infection? There's your answer. Okay, they used dirty needles. Who else? Does it have to be a dirty needle or an IV drug user? No, it could be patients who have catheters, okay, PICC lines, central lines. That's a nice portal of entry, correct? Okay. Or those who receiving dialysis, hemodialysis, okay, or anyone with prolonged IV therapy. So this puts the patient at risk for intravenous entry of the organisms. Okay. So this is the story of how the blood infection infects and damages the heart valves. Okay. So if you're a bacterium, what do you need to survive? Sugar, what else? Oxygen. And where do you find the best oxygen with a fresh supply of sugar in the body? Where? Brain maybe, but I mean, let's say I introduced you into the body. Where are you gonna end up first? In the brain or in the heart? You get stuck in the heart first. Okay, so therefore, let's say you entered a vein. Are you getting enough food there while you're in the vein? No, there's no oxygen here. Okay, so you're not likely to stay in that place. So you'll wait until you reach which side of the heart? A left side. Once you're in the left, now you discover, oh my God, all this oxygen, all this sugar. Will you leave that part? I'm staying here. All right. So they'll make a house. Okay. So we call these houses vegetations now. Right here, vegetations. So these are like, think of them as like houses that the bacteria, the multiplying bacteria will create. And because the only rough surface where you can really construct something in the heart, because the walls are smooth, right? I mean, we can't build anything there because they won't stick. But they'll stick on the heart valves because the heart valves have rough surfaces. There's tendinae there, so they can make the vegetations right there. And which valve are most likely affected here? The mitral is the #1 target. Mitral or aortic, but not likely the aortic because is the aortic really a peaceful place? No, the pressure there is way too high. Okay, so probably they can handle the mitral valve, so that's usually the affected valve. I mean, we can infect also the right side, but not likely, right? I mean, who wants to live on the right side? There's no food there. There's no oxygen, so they like the left side. Okay, so the most commonly affected valve is, of course, unfortunately, the mitral valve. So they make the houses. These are the two most common organisms, a staph or strep infection. And once they make the vegetations, they damage the heart valves when they construct these. And another problem is these vegetations, since they're not really constructed with high-rise quality materials, okay, they're just bacterial material, so therefore they can break off. Okay, so pieces of them can break off and become emboli, not blood clots, but foreign emboli just the same. And then we'll look at the manifestations later, where those embolizations will end up and clog. So here there's this destruction now, damage to the valve leaflets. So let's look at who are at risk. So which patients will likely develop this and which patients will this happen to? Chart 24-6. So we've got we already know about the IV drug users, the people with central lines. Okay, we got that. Who else? So I mentioned earlier under valve disorders, those with repair or replacement of the valves, right? So that's #1 right here. So they're the one group. Another is those with foreign objects in the body. Okay, because again, these are foreign materials. The body will not protect them. Okay, they do not fall under the immune system protection. You already had endocarditis in the past. So that means, did you have risk factors? Yes, that's how you got it. So therefore, it's not easy to get rid of those risk factors. And here are again congenital problems, usually at the involving the heart valve again. Transplant recipients, okay, including again involving heart valves. So we know about IV drug users, body piercings, hemodialysis. Now the not mentioned here really is the oral route. Okay, so the mouth is the number one portal of entry here. So people who have dental procedures done, but again, it means that the patient, for someone to go to the dentist and be at risk for endocarditis though, they must have these existing ones first. Does that make sense? Meaning, unless you've had heart valve repair or heart valve damage, if you go to the dentist, are you at risk for endocarditis? No, because you don't have these beforehand. Does that make sense? But if you have these and then you go to the dentist, could you develop endocarditis? So how do we prevent that from happening? Okay, very good. So if you have any of these history, then this is also again part of the your dental paperwork checklist, provided that you correctly answered. So the doctor, the dentist will place you on antibiotics first before they do the dental work. Okay, so that when they do the dental work, they'll give you the first dose today, or at least give you the prescription. Here, fill this, okay? Because of your history, you're high risk, so take these. All right. Let's go to manifestations. Because it's an infection, so what does anyone with an infection feel like? Yeah, nothing different. So you feel lousy, weak, malay, okay? You have fever, you're a baby, right? I don't want to go work. I want to go to school. Okay, so they have symptoms of a systemic infection. Because, however, of the under pathophysiology, so the bacteria makes the vegetations, right? So makes the houses, damages the valves. So does the patient develop valve disorders? What are the manifestations again? What will you hear? A murmur. Okay, so the patient will have either a new murmur, meaning they've never had a murmur before, so it's new, or they had history since they're one of these, correct? So that means they had an existing murmur, but then now the murmur changed, right? So there's a change in the existing murmur. And then will the patient manifest heart failure, signs and symptoms? Yes. Now, we're not done yet. So remember the embolizations? Okay, so bits and pieces of the vegetations that break off. Remember, the heart is not peaceful. It's always pumping blood. So therefore, pieces of those vegetations will eventually break off. Now, when they do that and then now they scatter, these are now the manifestations. They'll have petechia. You know petechia, right? Okay, so these are now microscopic bleeding to small, when those vegetations, those tiny emboli block tiny capillaries, so they cause them to rupture, causing the petechia. But these are microscopic though, very small. Then on top of that, you'll see small painful nodules, Osler's nodes in your fingers. Now, these conditions mentioned here, Osler's nodes, Janeway lesions, and Rot spots. Rot spots are in the eyes, Janeway lesions, macules in the palms, fingers. Same thing with the Osler's node, but the Janeway lesions are painless though. The Osler's nodes are painful. Okay, so these three are not found in any other condition. They're only seen in people with endocarditis. Nobody else will have this. So any other condition that you, when you see these, what's the only conclusion? This is endocarditis. As already mentioned, heart failure is the most serious complication here, besides sepsis. Because of damage to the valve, unfortunately, the patient had heart failure now. Okay, all because what did they do? They were IV drug users. Well, nothing we can do with congenital. Okay, so you were born with these congenital defects. But the others, like the body piercing, okay, so you had these piercings in your mouth, your nose, the nipple. Where else do you get piercings at? Yeah, belly button. Where else? Okay, so the other lips, okay. All right, so are they worth it? Okay, so think about endocarditis, all right? You don't want to have heart failure. Let's go to management. Oh, let's finish well, you already know the diagnostic test, because how do we know you have an infection? Now, how do we, diagnostic? And what will we take to, yeah, what blood work? Yeah, oh, that will show high WBC, but does that mean, oh, ESR, CRP will be high? And what else will we draw? How do we know what to treat them with? Blood culture. Okay, so we get blood culture, then we identify, okay, what infection are we dealing with? Then we identify the organism, then we give you the correct antibiotics. Okay. But we start them on empiric antibiotics, right? Do you know what is empiric antibiotics? Broad spectrum. Okay, so before we even get the blood culture reports, because that will take 2 days, what do? Wait 2 days and not give you anything? All right, so we give you broad spectrum or empiric antibiotics. All right. So these will be helpful with the diagnosis. So we see ESR and CRP elevated, white blood counts elevated with a left shift. And then how do we know there's damage to the valve now? Okay, echo again. Okay, so remember, this is no different from valve disorders. So TEE, which one's better? TTE or TEE? TEE is better. What did we say about prevention again? So what do these patients in chart 24-6, they have these. So what do we do to prevent endocarditis? Prophylactic antibiotics. Okay, very good. So don't forget. And do we promote good oral hygiene? Okay, so floss, brush your teeth, okay, 2-3 times a day. Because the mouth is the number one portal of entry, if you already have the risk factors in chart 24-6. Okay, with the antibiotics, since is this a minor or serious infection? Very serious. Do we want to kill the bacteria? Okay, so you think we will kill it with just 7 to 10 days of oral antibiotics? No. Okay, this will be 2 to 6 weeks of IV antibiotics. So since it's long-term IV therapy, what is our route? What is our IV access? Long-term. Central lines. What was one of the portals of entry mentioned in chart 24-6? People with central lines. Okay, so now, even if the patient is at risk for endocarditis, again, we have no choice, right? But to put in a central line. I mean, how else will we give them the up to 6 weeks of antibiotics? So therefore, they need a central line. Now, you'll see 2 different scenarios here, depending on which hospital you're at. Who, again, are these patients likely to be? No, I mean, who are going to be likely admitted for endocarditis? IV drug users, right? Okay, so therefore, are you going to trust these people to go home with a central line? All right, so that's the number one concern, correct? So if that's the scenario and it's in a city hospital, the city hospital will eat the expenses. They'll keep the patient for the entire 6 weeks with nothing but IV antibiotics only. So who's paying for it? You guys, okay? Because your city, so your taxes will pay for it. Now, if the patient is in a private hospital, same thing, they're IV drug users, blah, blah, blah. Will the private hospital eat because remember the reimbursement will be the same. The insurance company will not pay you for the 6 weeks of hospital stay because according to them, you don't need to keep them in a hospital. Send them home or send them to a rehab facility. Then we'll pay for those, not a hospital. Right? So how the patients will receive the IV antibiotics depends, particular individual scenario and which hospital you're working for. All right? Because I mean, is it practical for somebody to sit in a hospital bed for the entire 6 weeks and the only thing they're receiving is antibiotics 2 or 3 times a day? Nothing else is wrong with them. Is that practical? No, send them out, right? But the problem again is, what is this patient look like, right? Is it safe to send them home with a central line? What do you think they'll do if they're IV drug users? Yeah, this is nice. I don't have to use a needle. I have a central line right here. Thank you, right? And because besides antibiotics, because the patient develops heart failure, so what other treatments are involved? Okay, heart failure medications. Now let's go to the murmur. They had a murmur, correct? Will the antibiotics treat the murmur? What will happen to the murmur at the end of the antibiotic therapy? Will it disappear? It'll stay, right? Unless we again repair or replace the valve. So I won't repeat the surgical management because this involves again heart repair, valve repair or replacement. So we did that already. Any question on endocarditis? Okay, let's take a break. You look tired.